My dear students, in this video, I am going to discuss a few cases, and in that context, I will also cover certain key features of sepsis-induced AKI. Let us start with this case. The first case is a 62-year-old male with diabetes and hypertension who presents with fever, cough, hypotension with a mean arterial pressure of 55, along with tachycardia and altered sensorium. The chest X-ray shows right lower lobe pneumonia. The lactate is 4.2. Creatinine has increased from zero point 0.9 at the baseline to 2.1 mg per deciliter in 24 hours. Urine output is 0.3 mils per kg per hour for 8 hours. The patient has not been on any nephrotoxic drugs. So how do you approach such a patient? First step is to diagnose sepsis and AKI. Now, this sepsis meets the criteria of sepsis 3 definition and has infection plus SOFA of more than 2, including hypotension, hypoxemia, AKI, and altered mentation. This patient also meets the KDIGO AKI criteria because creatinine rises more than 0.3 mg per deciliter in 48 hours, and the oliguria is less than 0.5 mils per kg per hour for more than 6 hours. So at least stage 2. So no major alternate cause are there to show that like shock before sepsis or any drug exposure, etc. So this patient is likely to be a patient of sepsis-associated AKI and more likely to be sepsis-induced AKI. So what are the initial steps in assessment steps in this patient? So this patient, as an initial assessment, features around 3Fs and 3H. First is to look for the focus of infection. Now, focus of infection can be the lungs because this patient is having right lower lobe pneumonia, so which can be revealed by chest X-ray, and procalcitonin, CRP, etc., can be needed or can be used as a guide to guide the infection, although they are not diagnostic of infection, but they can be done. Second is the fluid status. You can examine the jugular venous pressure in a patient who has just been admitted without any any venous cannulation, and we can do a lung examination, including ultrasound, dynamic tests, and if the patient is ventilated to determine the fluid status. Third is the flow or the pressure, like the mean arterial pressure, the lactate, capillary refill, bedside echo for LV function, and IVC assessment. So these will all reveal the flow and the perfusion. So these three are the 3Fs, that is focus, fluid, and flow. And next comes the 3H, that one is the history, the baseline creatinine, because that is the basis upon which the further rise or increase has to be compared. Whether the patient has been on any nephrotoxins, whether the patient is having CKD, whether the patient was given contrast, whether there was any obstruction, or whether there is any recent surgery. Next to a history comes the next second H, which is hematuria. Hematuria or proteinuria can be easily detected by dipstick. Microscopy can be performed to look for the glomerulonephritis and distinguish whether it is acute tubular necrosis versus prerenal cause. And the third H is the hemodynamics, where we can look for the vasopressor dose that is necessary to maintain MAP, invasive blood pressures, heart rate, and the rhythm. The step 3 is to look for the immediate management priorities. So in this patient, one first step is resuscitate for sepsis with kidney protective indirectly, because resuscitation will improve the kidney perfusion, early appropriate and broad spectrum antibiotics within 1 hour of recognition, control fluid resuscitation with 20 to 30 mils per kg of balanced crystalloid, of course, with titration, and then reassess with dynamic measures, always to avoid any overload. Vasopressors to target a MAP of more than 65 millimeter of mercury. If we have to use norepinephrine as the first line, and this can occur early if fluids are unable to maintain that pressure. The threshold should be kept lower in these patients because they are at high risk of overload. And if we need to add, can add vasopressin as the second line. And the fourth is to maintain adequate oxygenation and ventilation, correct if there is any hypoxemia and acidosis. The next management priority would be to kidney specific steps. So stop the nephrotoxins, whether the patient is on NSAIDs, ACE inhibitors, ARBs, aminoglycosides. If the patient has to be administered contrast and it can be avoided if possible, then avoid it. Adjust the dose of all renally clear drugs and antibiotics. Maintain strict input output chart, daily weights, avoid positive balance wherever possible, target euvolemia rather than giving maximum fluids, always consider early vasopressor over repeated boluses of fluids. So these are the kidney specific steps which are involved in the management priorities and comes next. The third important management priority would be when to start renal replacement therapy in this case. Now, the typical indications in septic AKI are the same as for other AKI, but they tend to appear earlier and can be more dangerous. So, as we know that AEIOU, that is acidosis, electrolyte imbalance, intoxications, overloading, and uremic complications. These are conventionally said to be the reasons for which RRT needs to be started early. Now, they are similar for on even with non-sepsis induced AKI, but in sepsis induced AKI, they can be more dangerous if they are not looked upon. Refractory hyperkalemia, acidosis, uremia, they tend to occur more commonly and more early in sepsis-associated AKI. And also, since sepsis has a very high catabolic state, though if it so happens that there is a rising urea, which is not controllable conservatively, these patients will also require early RRT. So always label it as sepsis-associated AKI or early sepsis-associated AKI when the AKI appears within 48 hours of sepsis diagnosis. Let us go to the second case. A 70-year-old female with CKD3B with a baseline creatinine of 1.8 is admitted with urosepsis. She received contrast CT and high-dose vancomycin 48 hours ago, and now the creatinine is 3.5, urine output is 1 mils per kg per hour, but blood pressure is stable. So how do we approach this patient? Because the difference, as we can see, that the previous patient had no history of CKD, whereas this patient is a patient of CKD3B. Now, both patients are in sepsis. Now, this is a case of urosepsis that was systemic sepsis following pneumonia. So again, clarify the type of AKI in sepsis. That is the first step. We have to separate sepsis-induced AKI, where the kidney damage is driven directly by the septic process, or sepsis-associated AKI, where it is due to indirect factors like nephrotoxic drugs, contrast, abdominal compartment syndrome, severe congestive heart failure, etc. So they will also damage to the kidney, but they will be indirect. So that is why the difference between sepsis-associated AKI and sepsis-induced AKI becomes so crucial. If it is sepsis-induced AKI, because a lot of times early dialysis or early renal replacement therapy should be started so that the benefits are accrued very early. Whereas in sepsis-associated AKI, also we need to start, but the benefits may appear little late till the time other factors become controlled. Now, in this case, patient is having stable hemodynamics, no oliguria, recent contrast plus vancomycin. So this gives a mixed picture, but this is likely that a drug or contrast-induced AKI in a septic patient has occurred rather than pure sepsis-induced AKI. So we have to distinguish pure sepsis-induced AKI from such patients. So a structured evaluation is necessary because the time course of creatinine rising after the contrast has been administered or the drugs has been administered then at the sepsis onset. Urine exam is very important because muddy brown casts suggest acute tubular necrosis. Eosinophil suggests interstitial nephritis from antibiotics, etc. Imaging is important because renal ultrasound is necessary to rule out obstruction. Kidney size to see the chronicity of the disease, as we know that with chronic kidney disease, the kidneys become shrunken and fibrotic. The drug levels, because if the vancomycin has been administered and vancomycin level is available, it should be adjusted and stopped. Third is to be this look into the management focus. That is, stop or replace nephrotoxins, whether it is vancomycin, or avoid repeat contrast, continue appropriate antibiotics using non-nephrotoxic agents, also adjust their doses to the EGFR, optimize the volume, avoiding both dehydration and overload, careful diuretics if the patient is overloaded, because both dehydration and overload can affect the kidneys, one by virtue of reducing the perfusion and other by precipitating uremic symptoms, and closed biochemical monitoring by looking into potassium bicarbonate and the creatinine trends. So, in a septic patient with AKI, we have to look systematically for other contributors, that the drugs or contrast, obstruction, cardiac failure, before we label it as a pure sepsis induced AKI, unless the first case. Let us look into the third case. 55-year-old male with severe pancreatitis developed septic shock on day one, was resuscitated and remained on low dose norepinephrine. Creatinine stayed around 1 for 4 days, but on day 5 he develops AKI with a creatinine of 2.4, oliguria and generalized edema. Now, how do we approach such a patient? Now, this is again, we have to understand between early versus late sepsis associated AKI. If AKI has occurred within 48 hours of sepsis, it is early sepsis associated AKI. If the AKI is between 48 hours to 7 days of sepsis diagnosis, it is late sepsis associated AKI. Now, this patient has late sepsis associated AKI, which is associated with worse outcomes and more multifactorial causes because of persistent inflammation, nephrotoxins, hemodynamic instability, nosocomial infections, abdominal compartment, so on and so forth. So these are the patients which patients are likely to have a very poor outcome. So we have to look for the modifiable causes, re-evaluate for new sepsis source, whether there is an infection from the central line, whether there is ventilator-associated pneumonia, whether there is an intra-abdominal abscess, etc. Check the cumulative fluid balance and intra-abdominal pressure by looking into the presence or absence of abdominal compartment syndrome, ACS. Review the drug chart for cumulative nephrotoxins and high vasopressor dose, and also go for an echocardiography to detect new LV dysfunction or RV failure, because the cardiac failure can lead into this. The third step is the management strategy. That is, negative fluid balance should be pursued if patient is overloaded with cautious diuretics, and then renal replacement therapy if it is required. Optimize the hemodynamics of, that is the MAP, cardiac output, and also the microcirculation by monitoring the CRT, capillary filter, rather than just chasing the CVP or the urine output. Early nephrology involvement for RRT modality if nephrology needs to be involved, and timing, particularly in CKD patients, because often continuous therapies in hemodynamically unstable patients become important. And the late sepsis-induced AKI should trigger for a search for secondary complications, because misfortunes never come alone. So when there is late sepsis associated AKI, these patients are also likely to have other secondary complications. So those needs to be searched. So careful investigation, particularly bedside ultrasound and other investigations are important. And because they are associated with high mortality, they require discussion with the family about the possible prognosis and what needs to be done in case of any unforeseen situations. Now, why is sepsis-induced AKI different from simple pre-renal AKI? Because a lot of patients can develop pre-renal AKI, whether the patient is having dehydration, GI infection, acute diarrhea, or any other causes, they can present with pre-renal. Because in sepsis-induced AKI, the microcirculatory dysfunction leads to patchy, decreased capillary flow and shunting despite normal or high global renal blood flow. So it is this patchy decreases which matters ultimately and causes microcirculatory dysfunction in patients with sepsis associated or sepsis induced AKI. Next is endothelial injury and glycocalyx damage. We know that the glycocalyx is the target in sepsis, so there will be capillary leak, edema, impaired oxygen delivery in patients with sepsis induced AKI. Inflammation and immune activation leading to cytokines, leukocyte adhesion, microthrombi, all of this can cause tubular stress and mitochondrial dysfunction in sepsis-induced AKI. And tubular cell rather than massive necrosis, which is potentially reversible if there is no second hit. So one has to do early. The management should be very fast so that there is no second hit. And these are the points which distinguish sepsis-induced AKI from pure prerenal azotemia and from classic ischemic acute tubular necrosis. If you consider the follow-up and prognosis, sepsis-associated AKI is strongly associated with progression to CKD or worsening of CKD, and in roughly 25 to 30% of the survivors in recent cohorts. And of that, if it is late sepsis-associated AKI, then definitely the mortality is much higher. So we have to arrange nephrology follow-up, blood pressure and proteinuria control, avoidance of future nephrotoxins, and patient education on early care for infections in all these patients. So the take-home message from all these three cases would be that in any septic patient, actively screen for AKI with KDIGO criteria and treat it as a major prognostic warning. The key therapy is always high-quality sepsis management, early antibiotics, source control, careful fluids, optimized map, and there is no magic bullet. So there is no magic bullet, or even there is no magic renal drug which can prevent it. And relentlessly removing additional kidney hits like nephrotoxins, contrast, obstruction, fluid overload, abdominal compartment, cardiac dysfunction. This is very critical for the recovery of the patient. So we have to be continuously careful to avoid such possible second hits and initiate renal replacement therapy for AEIOU, the vowels indications, as I just mentioned, acidosis, electrolyte disturbances, intoxications, overload, and uremic complications. And always plan post ICU follow up because sepsis associated AKI greatly increases the later CKD and the mortality risk. Thank you.